Okay, so now we have an opportunity to hear from two of our sponsors of the consensus report. We will hear from Jay Bhatt, Senior Vice President and Chief Medical Officer of the American Hospital Association and President of the Health Research and Education Trust. And we'll also hear from Bernadette Mazurek Melnyk, who is Vice President for Health Promotion, University Chief Wellness Officer, and Dean and Professor of the College of Nursing at The Ohio State University. We'll start with Jay, and then we'll go to Bern. Thank you.
All right. Well, good morning, everyone, and I'll try to see if I can make up some time because I know I stand between another speaker, several speakers, and lunch. So I'll try to make some adjustments here. But one, let me just say we're honored at the American Hospital Association to have been involved in the Action Collaborative and to be a supporter of this really critical work. We see it, hear it, feel it every day from the people that we serve and those that we work with as our members. And to thank you to Chris, Pascal, for their leadership as chairs of this consensus study group, and to all the consensus study members for their incredible commitment and leadership. This is an extraordinary body of work in a short time, and really, I think, is continuing to light a path for us as a community on how we can envision a preferred future that looks different than it does today. So what I was going to do is make some observations. And the other thing I was going to do, which I'll adapt and change up given time, is use the lens of case studies as a way to not only illuminate the consensus study recommendations, but also offer perspective on things we may consider as well. But I'll do that a little differently here moving forward. So let me start with this. A reflection of the model in some ways that the consensus group pulled together. Now, when we think about this, there are several observations I'd make, and this also connects to the individual as well as the learning and improvement model that was reflected in the graphic. I think the approach and the conceptual model makes a lot of sense and builds on what the Action Collaborative conversations have been. What I would say is, one, that there is, both in the frontline care delivery, external environment, clinical environment, areas that we don't necessarily speak to in a significant way in the report. So think about, and I know some others mentioned this earlier, the ambulatory environment, the post-acute environment, the digital environment, the home environment, all part of the system in some way. So part of it is those stakeholders that are reading this report or taking the recommendations, and the public may have a lens and definition and view by which they see the language that shows up. So I think that's not just an important contextual point. I would say the other thing is we're in a system that's being asked to perform while transforming. Performing while transforming, which is not an easy thing to do right and can contribute to some of the challenges we're seeing play out. So how do we think about that? The other I would say is in the middle, where all three of these circles together, is the complexity of people and systems. So part of what we think about is what feelings do the external forces tend to create inside of me? What patterns have I formed to deal with the external forces or the clinical environment or the team and trust pieces related to frontline care delivery? And what is the net effect and cost of swimming in this water for an extended period of time? So part of what I wanted to lift up is that you could have a system that's functioning perfectly fine, but you may have folks, because of the feelings they feel leading to thoughts they have, then leading to actions that may ensue, that may disrupt that system in a way that leads to further burnout or unintended consequences, as was brought up earlier. The other thing I'll point out is this, that all these factors are underlying the work to try to develop a culture that will support their strategies in a system, while understanding without a strong infrastructure, which the recommendations point out, without a strong infrastructure to make it easy for people to do the right thing, you might as well stay out of the water. So we know the old adage that culture eats strategy for lunch, but infrastructure will eat both of it for dinner. And infrastructure, I don't mean in just the tangible, just the material, but I mean mindset. I mean the complexity of people. I mean, the values that were talked about earlier, that the study points out. I think we have to think about that infrastructure, and rightly so, as pointed out by the recommendations, and that communication to our stakeholders that are in health systems delivering care. The other is this. So I know that when I'm in the red, I'm running around looking for my charger. And this notion that I have a realization of, we wait till it hits red, 20% or less, before we look for the charger, and then we're doing that. Now, if we apply that to the system, what are the mechanisms by which we don't wait till it gets red, but there are moments when it's still green that we're recharging the system so that it stays green? And so I think the study report points to that, but I think there's more thinking and work to do moving forward around what are those resiliency factors for a system, and how do we act on it early on. The other piece I'll talk about is this thing about what the consensus study recommendation points to is something that we've been talking a lot about around the relationship between non-clinical leadership and clinical leadership at the HA. And as a result, launched the HEA Physician Alliance to do that work of bringing those constituencies together towards the vision that of a society of healthy communities where all individuals have their highest potential for health. So what we need is a common language to design a well-being system. So you have the CEOs, certainly, that you think about, and this is from our lens at the American Hospital Association, and I'll make other comments about other stakeholders. Physicians, nurses and other clinicians, the chief financial officers, the governance. So the report speaks about this as a really important group to think about. And right in the middle is this common language for resilience and well-being, where patient, families, and caregivers at the center. So how are we talking about these issues collectively with the group in a way that these stakeholders understand so that they're aligned around that common language for leadership and shared decision-making? So again, I think there's great content in the report to help us down this journey, but that's important. As you do that, this center grows. The common language grows, the ability to impact it grows, and I think we see that progression evolution. One of the things that we've been doing is doing a lot of work on awareness building, generating kind of both the awareness and the case for why this is important, both from a quality perspective, from a business perspective, from an operational perspective. And when I think about the recommendations, I think, I speak to 1, 3, 4, they all are important, but there's, in the lens that we may see with our members, a prioritization around these. And I'll try to run through some case studies that illuminate these recommendations, which are all very important, and make some comments about them. The other thing I'll say about this is that they're government and payers, sort of that impact all of these stakeholders as well, that we think about. One of the examples is thinking about creating a better work environment. So now there are a lot of examples. So one of the things I say is that when we see suffering as clinicians, we want to change the world. But we can't change the world without seeing sources of hope. And there are a lot of sources of hope that we can build on to help get to that preferred future. So UAB looked at a coordinated strategy for well-being, not only for the learner, but for the environment. So they focused on both a system and a learner approach. And what they did is they did a survey and then gathered 3 years worth of data for a baseline to look at the impact of new programs and interventions that were moving forward. And so what they did as a result was create an infrastructure to prioritize wellness, and that it's connected to how folks are looked at in the organization in terms of leadership. And they got creative on their funding. So when we talk about where do resources come from for this work, they looked at their local medical malpractice insurer and engaged them in a way to collectively generate resources. So, sustaining funding is a challenge. So now they're working on securing endowments and donations similar to the approach of this fund and other partners. The other piece that's really important is regulatory burden. And we've been very active on regulatory relief in a number of different ways, both at the system level with other stakeholders like prior authorization and other players in this ecosystem. So that continues to be important work, and I think critical to lift up. And to the point that was, that Dr. Buckeye raised around measures, how do we continue to work on meaningful measures so that we're doing the right things and appropriate things? This example is from HCA. So they have 1,800 sites of care that they were looking at. They had 3 different electronic health records with tremendous variation, and then looked at a whole redesign process to address clinical documentation burden. And as a result, standardized and implemented new nursing clinical documentation protocols. So the learning from this then shifted to other units. And so part of what I hear as lessons, we may have the lens of trying to change the whole system at once in an organization, but starting, as the recommendation said, piloting and starting and growing that is important. So they started with 11 hospitals, and people didn't want to be left out. And so it became a real important part of the work they do. The other piece in the report that isn't explicitly called out in a significant way, from my view, is the rural health community. So when we think about where care gets delivered, the critical access hospitals, the rural hospitals, the smaller systems, they may think about their approach and resources to this differently. Again, goes back to values and a process and approach. But I think we have to think about the journey they're on and where they are amidst the external environmental influences. So Avera Health is a rural health system. Again, it's a bigger system, so it can have an impact in a way that maybe other smaller systems are not. But there could be things we learn from even that, to the point that was made that some of the stuff may not take a lot of resources. So what they did was they created a program called Light, and this was driven by their CMO, who sat on the Systems Org Council, and made a business case by comparing average medical malpractice claim payment, average lost remedy from losing a physician, and to the point that was made earlier about suicide, saving one of the 400 physicians who commit suicide every year. So that case helped drive this program called Light, which included coaching, resources, and connection. So retreats such as Women in Medicine, couples retreat. Because part of this is also, when you think about the circle of my life, for a lot of people, my work takes up most of that circle within my life. And so how do you have an enhanced life that balances your work as well as life? And so part of this was they involved spouses and partners in the development of this program, to the point of families being really important. And that continued to have an impact as you see the sessions grew over a number of years with a community group, and then that led to increased organizational investment. So I think the report points out probably is that starting in a place that leads success can lead to greater success. This is a statewide approach from the Minnesota Hospital Association, so working with a lot of state hospital associations on this issue. And so they surveyed their whole state and then used that information to continue to provide intelligence to their hospitals and leadership at the board level with the CEOs and at the governance level. So this is an example of how, I think that you can't measure without the notion of understanding that you have an approach to take once you get that data. So let me, this one's interesting because it speaks to the invest in research piece. And they looked at the science behind how a health system literally causes biological changes in the brain. And changes cognitive abilities help to link system factors, patient experience. And so they made the physician burnout issue a patient experience issue that was lifted up. And so they've looked at both human factors, cognitive, and other process engineering approaches. This goes, example is Novant Health goes to, you can't lead a team or organization if you can't lead yourself. And so they have, every physician and nurse that comes into their organization goes through this 3-day program, and it's invested in by the leadership. And you see the impact on both engagement and alignment. So the idea is that we care for our clinicians and they care back. And so they've gotten more involved in the organization in a number of different ways. And we've adapted this to do this in a heterogeneous population of people across the country through the HEA Physician Leadership Experience. So at the intersection of resilience and burnout. This part, again, goes to the piece of complexity of people. So the story I told myself when I was a young kid, that was a story that extended for many, many years, that led to burnout for me, because I had a father who worked a lot. And I saw that you work hard, you get success. That's the achievement model. And so that's what you keep doing. The other model and default was pleasing everyone or saying no. Or that model had an impact in the home life, had an impact in my own personal life. But then I always wanted to say that I was right. So you have this conclusion that emerges, but you have a filter based on life experience, and that filter ends up being one that helps you say that you're right, so that you can keep going about your story that may not be a true story. It's a narrative that you created based on your childhood, based on your experience. So this part helps really impact this issue of what keeps people from achieving their potential, and even in a perfect system might still experience burnout. And the other is empathy mapping. So this is an exercise we do around empathy between people that come from different backgrounds, experiences, and cultures. So this is, I think, what we continue to need in this work. And so this is the way we've laid out the approach. Create infrastructure for well-being. First, you got to decide that you're going to have infrastructure, and it's going to the values orientation around this. Then engage your team, then measure the well-being, and then the interventions based on it, implementing programs, testing it through the evaluation, creating sustainable culture. This is reflected in the consensus report. This just lays out the steps by which we take this. And let me just end with this. The ancient redwood trees of Northern California, huge as they are, have very shallow root systems, yet they cannot be blown over by the strongest wind. The secret of their stability is the interweaving of each tree's roots with those that stand by it. Thus, a vast network of support is formed just beneath the surface. And even in the wildest storms, these trees hold each other up. And so many have alluded to this concept all morning, but that this future can only be realized if we have an interconnected system that's working effectively together, just like the U.S. women's soccer team who plays for each other and lifts these issues that are important up. So I think that the Redwood symbolizes for me the work that we need to do and have done. So thanks for all your work on this important issue.
Good morning. I'm not the best example of a chief wellness officer today because I am sick, but I am going to role model by leaving directly after my presentation to take good self-care, which we need to do more of. I am so blessed to work at a university who invests sizably in wellness. We all know what the problems are. And I really want to thank the Consensus Committee because what you're going to do for all of us in the field is give us these powerful evidence-based recommendations that we can take back to our organizations to further fuel what we are doing. People who know me know I don't do anything slow. So I really like the title of the consensus study, the emphasis on action. Think about this old saying. It takes 17 years to translate findings from research into the real world. We cannot let these evidence-based recommendations take that long. We have known for decades 12-hour shifts for nurses lead to poorer health, mental and physical, lead to more medical errors. But we continue to promulgate 12-hour shifts. That is a system change that needs to be done. So at Ohio State, we have a very big wellness team, And I think we've heard from people here today. You've got to coordinate. You've got to align. You cannot exist in silos. And we have worked very hard to do that at Ohio State. One of the successes we have had in bending our culture to wellness is the fact that we sit leaders down in this council. Top leaders from across the university sit together on this health and wellness council once a month. We create our strategic plan, the implementation pieces, but most importantly, we stay aligned in what we do in our work. So recommendation 1 in the consensus study is to create positive work environments. And I put this slide up here intentionally because if you do this top down, it doesn't work. If you only do this in the grassroots, it doesn't work. You need to target intervention strategies to individuals and small groups. This middle management layer is key. If middle managers aren't walking the talk and supporting well-being, the people below them won't do it as well. Top leaders have to walk the talk. There needs to be system change, as we've heard about today. But culture eats strategy for breakfast, lunch, and dinner. So you can have the best evidence-based strategies in place, but if people go back to a unit, a culture that does not support well-being, it's not going to sustain. Here's where leaders give up. And think about this. The average C-suite executive is in place only 3 to 4 years. What can you do culturally in that time point? Culture takes time to bend. 5 years, 10 years, in some places longer. So I was struck when I went through the report. This is the framework that we adopted years ago at Ohio State. It's the Socioecological Model. So we target individuals with protective skills building interventions. We also target the family and social network, the workplace culture and environment, and then policy. And we are meticulous about tracking outcomes because we take an evidence-based quality improvement approach. Now, we just collaborated with the American Association of Critical Care Nurses. We replicated our published study from last year. These findings were even more abysmal. 40% of these critical care nurses reported depression. Depression was the leading cause of medical errors. But here's what's really important from this study. Nurses who perceived that they were supported in their cultures for well-being support, they had much better physical and mental health outcomes. So communication, making visible our efforts, saying we do this because we care about our families, are so important and directly impact health and well-being. So when I get asked a lot of questions about how do you do this in the grassroots when you have little money to invest, this is such a successful evidence-based strategy. We have about 700 clinicians, faculty and staff who work with our wellness team to create cultures of well-being in their units. A lot of places have these, they call them wellness champions. We call them Buckeye Wellness Innovators. But we have a structured program for them. Unlike a lot of other places, we sit down with them to do strategic planning. So we do a lot of individual work with these people. Well, recommendation 1B is focused on the clinicians and giving them protective skills. We know that this alone isn't good enough because we have to have system interventions too. We would not send a construction worker out to a work site without a hard hat. We can't send clinicians day to day into work without giving them evidence-based strategies that we know work. And as part of a recent systematic review of this NAM Action Collaborative that's under review right now for publication, these are 4 evidence-based strategies that I believe every clinician should be equipped with because there's a lot of evidence to back these interventions up. This is a unit. These are some physicians and some nurses. We saw an uptick in stress in one of our hospitals last year. So we rolled out this Just Breathe stress reduction system initiative. And already in a year, we are seeing good outcomes. Recommendation 1C really points to the importance of routinely measuring and monitoring outcomes, and then using those outcomes to drive strategy. We hired Truven Analytics, which is an IBM company. They give us what's called a health and productivity index score. I get these scores for every single one of our 7 hospitals and colleges at Ohio State. And I go around then and I present the data to the executive teams. This past year, we saw a big rise in depression in one of our hospitals. So we're able to hotspot and then send our wellness team in to really work with that hospital on individual and system change. What's really nice about this, I can let the top administrators know These are the indicators that are pulling your score down. These are the ones that are helping your score. Well, we had about 20 years of research on a cognitive behavioral skills building program. We adapted it for nurses. We tested it with great outcomes. Now we're scaling this widely, not just for nurses, but for other healthcare professionals in our system. We are extremely focused on learners at Ohio State. We have 7 health sciences colleges. And by the way, the health science profession with the highest suicide rate is veterinarians. And I am really deeply involved in veterinary medicine right now because my youngest daughter just graduated from Ohio State Vet School, and I was able to give her her diploma with the dean of the college in our famous horseshoe. But we started a wellness onboarding program for all our health sciences students. So when they start medical school, dentistry, vet med, nursing, they take a wellness assessment. Then we pair nurse practitioner students with these other health professional students to serve as health coaches. There are a lot of universities with health profession schools who could leverage those students more in improving population health and well-being. We also have allocated FTE for directors of academic wellness programming. So they actually get FTE effort to make sure wellness is integrated throughout our program. We know CBT works for depression and anxiety, but so few people get it. All our medical students, nursing students, veterinary medical students are getting this CBT-based program right first semester to equip them with protective skills. Lastly, recommendation 5, provide support to clinicians and learners. We have just expanded embedded mental health counselors in our colleges, so our students don't have to go to counseling and consultation. It makes it much easier. We also have a program called STAR, Stress, Trauma, and Resilience, that really works with our clinicians to help them coping with all the stress that they experience in their daily work. Lastly, our university is investing in research on this topic. We just put out a call for interprofessional proposals to improve mental health in faculty, learners, and clinicians. So my end saying, Benjamin Franklin, an ounce of prevention is worth a pound of cure. We have to turn crisis intervention more so into prevention. Thank you, and thank you for your wonderful work.